I wanted to round out the overview we've been doing throughout the course of different approaches to hospice and palliative care, and we've seen already that it has evolved in a variety of ways under a variety of different forces in different societies and in different economic conditions and political conditions. And so I did want to talk about another approach and use an example of a local expression of this, and that's the Near North Palliative Care Network. This is probably the oldest approach to palliative care in the region, and it was founded by Joan Burnett in 1987. And you can see here their logo of the butterfly, and that's become a kind of international symbol of hospice and palliative care. And this network is known for doing fundraising where they release live butterflies to represent the souls of the people that they've been working with throughout the year. And so they're very clear on their website that they want to be decentralized, and so they operate in parallel as a charitable organization alongside of palliative care in the hospital and palliative care at the hospice. And so on their website, it says they're a registered charity providing one-stop, face-to-face, and online volunteer visiting hospice community services with their main office in North Bay, offices in Sturgeon Falls, Mattawa, and Sunridge. So they're serving these small, smaller communities in the region. And so their mission statement states that their core values are human dignity, compassion, social responsibility, community service, and excellence. And so they state that they work with anyone with a life-limiting illness. Family and caregivers are at the center of care, along with compassionate listening. So we can see that they have the hallmarks of all forms of hospice and palliative care, and they're dedicated to offering emotional support, information, physical support, respite support. So a lot of the volunteers will take over if one of the family members needs to go somewhere or needs a break, social support, spiritual support, grief and bereavement support, living wills, and a lending library. And so they go through the different points. I will link this to the post of how they do this. So in terms of, just to give an example, in terms of emotional support, encouraging clients to take active roles in their own care, acting as an advocate by ensuring that the client's wishes are respected, providing nonverbal support such as holding a hand, sharing an activity, discussing illness, death, and grief openly. So you can see right off the top here, that's a lot. So they do extensive training with volunteers in order to help them to provide these services. And so in terms of physical support, hospice volunteers will offer what they call compassionate response to a client's physical and personal care needs, which may include assisting with bedpans, going to the bathroom, positioning in bed, and aspects of grooming. Social support, our volunteers provide companionship to the client and support to family caregivers. So we can see with the Near North Palliative Care Network, they're leveraging the community as in a volunteer capacity to work with palliative care. So this is quite a different approach to the more medically based care, but you can see that it's all compatible. And so also with a network like this, it's allowing services to go out into areas that are underserved. I want to start now talking about what's often referred to in healthcare as cultural competency. And this is a larger issue that I talk about in a number of my courses, and I often make the argument that I personally believe that everybody should study some version of a world religions course, because we're living in a country and society that has such a diversity of cultural backgrounds and religions, and this has an influence in every aspect of life. So it isn't just in healthcare. So this is a much larger issue in certainly in Canadian culture, and so we have the difference in culture, but also in religion. And so this becomes very important with anybody working in a profession dealing with the public. And so the Registered Nurses Association of Ontario has released a number of documents on this topic. And so I'm just quoting one section for diversity in healthcare regarding anticipated outcomes. So in the larger document, they talk about the idea that if this is dealt with properly, then we see better outcomes for everybody. We see a better working environment, we see better care for patients. So it's a very complex task, and it's easy to kind of write about, but how it actually works is obviously very complicated. And so a workforce composed of nurses who are open-minded, inclusive, and respectful of all colleagues and recipients of nursing services. So that's, of course, just the bare minimum that awareness of diversity will allow for this to be the case. And of course, there needs to be an educational component in this, and that's why I made that point about the necessity of education. Individuals of the workforce identify and are cooperative with one another to address barriers to equity and diversity and build practice environments in which every person's contribution is valued, thus allowing the full potential to be maximized. So many bureaucratic documents use this kind of language. Unfortunately, we know it's not always the case in practice. And so some of you may know that during COVID, there was an absolutely terrible case in Quebec where an Indigenous woman was being refused proper care in the emergency room. And so we know that this is not always happening in practice. And so again, I think that education component, and not starting at university, long before university, is very important. And so, of course, these individuals refuse to participate in discrimination, harassment, or bullying and address the issue in a way that will affect change. So obviously, the government and these different organizations are trying to address the problem, but as I've been saying, I think that the education piece is just so important, and I feel like nursing faculties, medical faculties are starting to realize this, and I'm hoping that the humanities and these medical faculties will come into closer conversation as a result. I want to talk now about the role of religion and its relationship with cultural competency. I know in the healthcare professions they do training in this. And I just want to talk more specifically about how religion could potentially fit in with this. And so if we look, this again is taken from an RNAO document. Cultural competence ranges on a continuum from eliminating the negative end of destructiveness, racism, and abuse to the positive end, where cultural diversity is valued and has the potential to create innovative, transformative opportunities that maximize health, economic, and social benefits. So of course, I'm coming from that angle that actually this diversity is a resource. It's not a problem. And unfortunately, in the past, I think religion has been often, not just in healthcare, just in general. If we look at the media, it's always, terrorism and so on. It's always sort of the problems that it causes rather than recognizing that it's a resource. And so this is, again, a larger cultural conversation. Cultural competence in the workplace can be described as a congruent set of workforce behaviors, management practices, and institutional policies. So this is all very, very bureaucratic, but certainly there's been a lot of work done on this. And I just want to give an example in terms of hospice and palliative care that obviously when you're dealing with the human body, religion's going to come into it. So many, if any of the students in this course have taken my Health and Healing course or any of Dr. Strigley's courses, we talk about this. So the idea of attitudes to the body are completely infused with religious and sacred meaning within many different religions. And so they will typically have practices at the end of life. So for some observant Jews, there's actually a whole process that's done by a group of people that bathe the body and do ritual prayers and so on. So this is also true in the Muslim community and in Buddhist community and in the Christian communities. And so we see that the knowledge of this becomes very, very important. I would argue it's important for everybody, but it's certainly important in terms of people that are working in healthcare and particularly in end-of-life care. And so certainly there's been a conversation going on about this for a while, and so I'm going to be just drawing on the Oxford Textbook of Spirituality and Healthcare, in which a number of different people have written on this topic. And so Bruce Rumboldt in chapter 26 writes on models of spiritual care. And so this is always a challenge because we are in a secular society that doesn't combine religion with the political and economic sphere. And so how do you do this then? And so what has happened in the past is generally the response has been do nothing, just throw it out because it's too complicated. But I think there's a different approach that can be taken. And so many people have been working on this. So the idea that we're having to work that secular religious divide, which can be very challenging because obviously there's concerns about, for instance, if a nurse is very religious, that they want to proselytize to the patient, which is of course completely unacceptable. So how do we work with that? But as with many other people in the field, I don't think that's a reason to throw the baby out with the bathwater. And certainly almost all the hospices that I know of have a sacred area, a prayer room, like that. In my experience, they're treated as a kind of afterthought. I'll talk about that more when we get to architecture, but certainly that's one way to address it, is to create a designated space. We also see that many hospices and palliative care units have access to clergy or chaplains, so people that are specifically tasked with working with people who are either sick or at end of life. So Bruce Rumboldt talks about models of health and healthcare, and he makes a very important point, which is that largely the discussion has been completely shaped by biomedicine, and you're just kind of trying to slot these other things in, and they get a sort of a passing notice. And so really this is addressing that and trying to expand this so that it's a central part of the whole process, particularly at end of care. And so so in chapter 29, Restorative Medicine, it's written by Christina Pachelski, who's been one of the major players in this. She's herself is a medical doctor in Washington, and so she founded an institute dedicated to trying to bring these two things together, and she herself is actively religious. So in herself, she's bringing together kind of medical science and religion. And so she is saying that she talks about spiritual diagnosis and the resources of strength. So she says the diagnosis of chronic or life-threatening illness and other adverse life events can lead to spiritual struggle for patients. So again, particularly with illness and end of life, that's a very common experience that people will start to deal with these existential questions that perhaps they hadn't been thinking of up until that point. And so she talks about the idea of spiritual distress. And so she includes on page 202 a whole chart of what this can look like. So existential concerns, lack of meaning, questions about the meaning of one's own life, concern about the afterlife, questions about the meaning of suffering. So these are all typical existential religious questions that anybody might have at various points in their life, but they become particularly salient in hospice and palliative care. So she goes on to say, anger at God or others, concerns about relationships with the deity, despair, hopelessness, grief, the desire for reconciliation. So for instance, there are many cases where perhaps the person has left their religious tradition, but at this point in life may want to return to it. So that may be something that the person's wanting to achieve before they die. And so she talks about the idea of spiritual screening. And so there's been a number of different models created. So again, as we've been saying, we can say these things, but how does it work in actual practice? So one of the ways is a number of different models have been developed for creating a kind of assessment tool. So she talks about spiritual screening, history, and assessment are formal tools of the medical history. So as part of medical history, this can be done, during which patients are asked about their spiritual, including religious beliefs. Clinicians do a spiritual screening or healing. Chaplains do a spiritual assessment. Usually a nurse or social worker does a spiritual screening upon triage or admission in settings such as hospitals, nursing homes, or hospitals. Spiritual screenings might not be performed in outpatient settings. So this is what's starting to develop, this idea that this screening can be done right at the beginning. And so if the person's not religious, then that's not a part of it. But if they are, that becomes a possible component of care. And so in this chapter, she talks about communicating with patients about spirituality and religion. And so one of the most effective tools that's been developed is the FICA FICA spiritual history tool that is now being used in the United States. And so the F stands for faith and belief. Do you consider yourself spiritual or religious? Do you have spiritual beliefs that help you cope with stress? If the patient responds no, the physician might ask, what gives your life meaning? Sometimes patients respond with answers such as family, career, or nature. Importance. What importance does your faith or belief have in your life? Have your beliefs influenced how you take care of yourself in this illness? What role do your beliefs play in regaining your health? C, community. Are you part of a spiritual or religious community? Is this of support to you, and how? A, address and care. How would you like me, your healthcare provider, to address the issues in your healthcare? So this is one example of a screening tool that can be used in different settings. I am not clear on if this is ever used in Canada. Canada has been very slow to engage with any of this. It's been much more prominent in the United States, to my knowledge. So we can see that there are ways that this can be engaged while still recognizing that healthcare is a secular setting. So I want to move on now to looking at what this might look like in actual practice. We've talked in this course about Cicely Saunders' idea of total pain, and that idea that there are dimensions to pain, and we've also discussed how difficult it can be to get at this and what that means. And so I think we're pretty clear. We know what emotional pain is, but spiritual pain, I think we're less versed. And I often say there's a kind of tone deafness to religion oftentimes in our culture, and this is because increasingly people aren't raised with religion and they don't really understand it, and some people are militantly opposed to religion, and so this can cause a kind of inability to recognize that the spiritual side of life has this impact. And so I want to give an example of what this actually looks like. This is an article written by a palliative care nurse, and out of her experience, and I find it very helpful at getting at what we're talking about. So she writes, nothing could have prepared me for this patient. I heard him even before I saw him. Piercing cries of pain emanated from his room. As a pain resource nurse, I had been asked by our hospice to reassess and try to relieve his immense pain. And so she says, although pain is a personal experience influenced by culture and belief systems, we often overlook spirituality when assessing a patient's pain. Okay, so again, that idea that pain isn't some objective fact, it's impacted by all of these different aspects. So she goes on to say, as I entered his room, I saw a 24-year-old Cambodian man writhing and crying in pain. His name was Sari Samanang. He had liver cancer and both of his legs had been amputated below the knee, the result of a landmine explosion. He had been rescued and brought to the United States by Christian missionaries and spoke limited English. Although Mr. Samanang was receiving 1,000 milligrams of morphine a day by continuous infusion, his pain was excruciating. The hospice team was discouraged that upward titration of the drug had failed to improve his condition. So obviously the first thing that the nurses did was try to handle the physical pain, and so they're upping his dosage, but this isn't having an impact. So even though everyone present knew he was in pain, they were sort of at a loss to know what to do with it, and hence she had been called. So So it says, although we feared that increasing the level of medication might hasten his death, we considered titrating the dose to an even higher level. Meanwhile, the minister from Mr. Samnang's church visited daily. As a friend and counselor, the minister tried to comfort him. During a hospice team meeting, some members suggested that at least part of Mr. Samnang's pain might be rooted in memories of the Cambodian conflict. The hospice physician considered administering the drug midazolam, which can help dying patients forget painful events, even though ultimately we decided to try to discover and target the true source of his misery. I think this is a very important point here, that this can be our go-to, in not just in medical facilities, but in general in our society, that if something's painful, we just want to mask it. And this very much goes against the whole philosophy of hospice and palliative care developed by Saunders, who's all about being as conscious as possible and trying to resolve problems in relationships, problems from the past. So they decide they're not going to go that route of just masking it. And this leads me to another situation I had heard about in this case in Australia, where the dying person was having visions of a ship. And according to the person that was telling me this, they just started drugging him. They thought he was hallucinating. But in fact, this is a well-known thing that happens at death, where people have visions of this kind, and it's very much recognized in religious traditions. So again, how we look at these things will differ depending on the lens that we're bringing to it. And so the nurses are clearly, they've been talking to him, they know about his history, and so they know that he's come from this very tragic past. And it says, it was at this point that we really began to focus on the significant spiritual changes Mr. Samnang had undergone over the past 2 years. He had recognized that Mr. Samnang's faith was very strong. He had responded to prayer dramatically, but we had only recently realized that although he was currently a practicing Christian, he had been raised a Buddhist. We proposed a visit by a Buddhist monk to evoke happier memories and to provide spiritual comfort. And I just think this is just absolutely incredible what the nurses have done here, where they've listened to him. They know that he's a recent convert to Christianity, so he spent most of his life as a Buddhist, so they're going to call in a Buddhist. So this idea, it's not that they're rejecting the importance of the minister, but they're also going to call in a Buddhist because this is more linked to his past and to his culture. So they said he was both delighted and dismayed over this proposal. While he welcomed this visit, he felt that any contact with Buddhism would signify betrayal to his Christian rescuers, but this wasn't the case. His minister, friends, and members of the church to which he belonged supported all attempts to enhance his comfort. So again, I think this is very remarkable, this idea that the church is basically like, do whatever is helping this person. And so he admitted that although he was a Christian, he wanted to die a Buddhist and have a Buddhist funeral. He wished to overcome his pain through harmony, mental clarity, and balance. He wanted to clear his mind of all thoughts, even those of a religious nature. So she goes on to say the solution was simple yet profound. Both his minister and the Buddhist monk would visit jointly to show their alliance and support of his decision to affirm his Buddhist heritage. The hospice staff arranged for the meeting to take place immediately. The monk and minister alternately chanted, I think this is just incredible, alternately chanted Buddhist meditations and Christian prayers. As Mr. Samnang had requested, the Buddhist ritual eventually predominated. So I think this really shows a number of different things that are being discussed here. And so this idea that he's in distress for a number of reasons related to his connection with his culture and with his religion. And of course, this is always intertwined. And so the way that these hospice care workers resolved this, I just think is absolutely so nuanced. And so it says, she writes, what followed could only be called a miracle. Mr. Samnang's pain appeared to vanish. Although the morphine remained at 1,200 milligrams, Mr. Samnang's pain finally seemed under control. To staff observers, it appeared that his mind was clear and he felt serene and peaceful. He said that he had never been more comfortable. He appeared to have transcended his pain by resolving his spiritual conflicts. And so I think this just really illustrates the dimensions of pain and how these other dimensions can actually be what's causing the pain. So she says, this is a lesson that he taught all of us. As healthcare providers, the impact of spiritual comfort hasn't always been as apparent to us as pharmacologic relief or even emotional support. We thought we knew the dynamics of the pain experience in patients, but we had never seen the resolution of spiritual conflict would have such a profound effect. Mr. Samnang died peacefully not long after these events. He had continued to require 1,200 milligrams of morphine daily, but he had declined any additional medication for fear that it would affect his mental clarity. Following the Buddhist tradition, his body was washed and wrapped to be cremated. In the end, serenity replaced anguish.